Again, just for everybody, the background, because I know we have people from out of the state of Colorado. The Center for Women's Health Research is historically recognizing that research studies, and I know that, believe me, I was shocked about this, they excluded women from almost everything that was researched. And so, the reality is that the studies are now set up to try and answer some of these questions. And the researchers at the Center for Women's Health Research study women's health and sex gender differences, particularly in the area of cardiovascular disease, diabetes, and the intersection of mental health and physical health. They're committed, as is Arrow, to the future in which research includes women and men and accounts for the sex and gender differences in order to shape better health for everybody. And the center's been doing this through research, mentoring, training, through educational events, which is this is one of them. And I tell you, I'm really thrilled that we have Dr. Burger with us today. She's the chair of the Department of Orthopedics at the University of Colorado School of Medicine and a renowned spine surgeon. After obtaining her medical degree with honors in South Africa, Dr. Burger became a captain in the South African Defense Force Medical Corps, where she treated injuries of war and mine explosions. Following residency, she dedicated her career to spine surgery and received national acclaim as the first female surgeon to be named a prestigious ABC Fellow. She was recruited to Louisiana State University in 2001. We'll talk about that later. And in 2006, she joined the University of Colorado Department of Orthopedics, where she founded the Adult Spine Unit. She has won numerous awards for her research and received international recognition for her work on theraplastic behavior of metal rods and on the advantages of disc replacement. After serving in various leadership positions in the department, she became the first recipient of the Robert D'Ambrosia Endowed Chair in Orthopedics. I am honored and pleased to have her with us today. I am excited that she's going to be sharing with us topics of importance. And I'd like to just one more time remind everybody, please put your phones on mute or your computers on mute. And with that, Dr. Burger, I'd like to turn it over to you. And as a reminder to everybody, in the chat box, you are able to ask any questions that you may have, and then Dr. Burger can address those as she goes along or at the end. With that, Dr. Burger, I'd like to turn it over to you. Thank you again.
Thank you very much, Mr. Bird. Thank you for the illustrious introduction. I just want to check if my voice is projecting appropriately. Can you hear me?
Yes. I'll speak for everybody, Dr. Burger. I can certainly hear you very well, so not a problem on my side.
So thank you for this opportunity. I am going to start the presentation. So when Judy Regensteiner asked me to give a presentation, I said, well, what shall I talk about? And she says, you talk about the smorgasbord you talked about before. Because I'm a spine surgeon, and so back pain is my passion, which sounds a little weird because patients with back pain can be a pain in my butt, but it is what I do. I am very animated usually, so it's hard for me to sit down. So I apologize if it comes over bland, but this is who I am. I'm very honored to work at the University of Colorado. I'm surrounded with unbelievable people and anything is possible here. And this is why I was able to excel in my career, is because there are a multitude of opportunities here and in Colorado. And if you want to step up to the plate, it's really easy. So from a very small campus, I came here when we were still a small hospital in, I think, was it 9th Street down near the old VA. And now we're this 2 square mile campus and still building and expanding. And I have no financial disclosures pertaining to this presentation. So let's start off with spine anatomy. So our spine consists of vertebral bodies, and then we have discs in between, which is our shock absorbers. the whole purpose of the spine is to give a protective casing for the spinal cord, which is an extension of our brain. And then from the cord comes out nerves that has a myelin sheath over it. Our spine is positioned in the middle of our bodies. It is not in our back. If the spine was in our back, we would be quadrupedal. So when you stand up, your spine is in the middle of your body. And that's, even though you feel your back, it's big enough and it has certain curves to maintain an upright posture. So when people present with back pain, where do you start? Back pain is a symptom. It's not a disease. And it's very important to understand that if your back hurts, that it's part of a symptom, and it can be a myriad of pathologies that causes that. So the best way to think about back pain is to think about it in different age groups. Because what's wrong with little babies is not what's wrong with your grandmother. So the 7 ages of the spine is the following. When kids are born, they can be born with spinal abnormalities like a spina bifida. It can be a hidden or it can be an occulta. It could just be a sac, or there can be nerves in it and they can have subsequent paralysis in the legs. It's related to folate deficit during pregnancy. Little babies can also get infections in their spine, of which the most common is Staph aureus, Haemophilus influenza, and Klebsiella kinkei, which is a newer organism diagnosed about 6 years ago. Then as they go from babies to infants and they start to walk around, you will sometimes hear that the patient mother comes and says, well, he was walking fine until a week ago and now he doesn't want to walk. Because they can't tell you what's wrong. And so young patients can get a spontaneous process of discitis. You can see here's a vertebrae, and in children, the disc spaces are almost bigger than the bone. And you can see this bone is really white, and this one has white with a hole in it. So on a CT scan, this is what it looks like. And they can get infections. These infections need not be bacterial. It can be inflammatory. We don't quite understand it. They can have little tumors in the spine, which is usually benign. Or it could be the first signs of juvenile onset scoliosis, meaning under the age of 10, or they can have congenital malformations, and once they start to stand up, their spine becomes unstable. Now let's move on to the adolescent. If you have adolescents at home, you know that most of them are sitting in front of computers or on their cell phones. They're always slouching. They don't do enough exercise. And they will often complain of back pain. It can be related to other conditions, especially in girls. It can be related to their menstrual cycles. But if you isolate it to their back, again, infections. Just like we're in COVID right now, infections is always a prime diagnosis for back pain in any age group. There can be benign tumors in adolescents that occurs, which is like little bone islands. Or especially in boys, they can start to get slouchy, and that forward gaze is called Scheuermann's kyphosis, and it's actually an inflammation of the discs. Or they can have what this MRI shows, a slippage, where one vertebrae slips over the other, spondylolisthesis, the Greek, spondylovertebrae listhesis, slipping, and the one vertebrae slips over the other. Very common. There are a whole lots of reasons for that, but we also see this in our high grade sports kids where you stop and turn. So soccer, golf, if you play football, I'm sure the whole Broncos team have spondylolysis. And then, especially when we talk about women's health, idiopathic scoliosis, girls starting with a curve. Now, girls in the adolescence are shy. They will not undress for you like in this picture. They don't want their mother to look at them. They don't want anybody to look at them. So this is a silent disease. There's no pain. Very seldom is there pain. But you can develop a significant curve, and it can get up to 45 degrees before it's even visible for the lay eye. Now let's look at young adults. These are invincible young people that are first year in college and that do really stupid things. They can get disc herniations. or they can still have spondylolisthesis, and here's another example of that slippage with the fracture that occurs, or they can just have fractures because they jump off high cliffs and they try to show off, and and they're invincible in that age. So when a young adult comes, we look for disc herniations, we look for fractures, and we look for overuse fractures, which is the spondylolisthesis. Now you come to the Middle Ages, and I'm sure most of the people on this call is in that age group, unfortunately. And that's now when your spine starts to show the aging. It's important to know that your spine grows until the age of 27. And not longitudinally, you're not getting taller, but there's a lot of growth mechanisms in the spine. And the moment you reach 27, you start to age. You're over the hill, you're done, you can't get more bone mass, you can't get more disc height, you're just done. It sucks, but it's true. So at this, when we're in our middle ages, the discs that started to degenerate in our late 20s from all the stupid things we did, now starts to show up on an MRI. You can still get a disc herniation. If you try to lift a piano and that kind of stuff, you can get a disc herniation. Your discs start to degenerate. Here's an MRI. This is a vertebrae, a disc, a vertebrae, a disc. And our discs look like little fishies, white and bright. And then your disc starts to go dark, just like the rest of your life. And that's disc degeneration. It gets a little darker. So the white is fluid. And as we get older, our discs get a little more hard, and the fluid is basically absent. And that is what is disc degeneration. And we'll talk more about that. Now let's look at our older adults. And I'm not going to go there to say who's older or not, because some people age early and some people age late. Once you're older, you're past the disc degeneration, you still have disc degeneration, but now the disc degeneration becomes multifactorial. It's not just a dark disc. The disc starts to crack, you lose the height of your disc, you start to push on your nerves in the back of your spine, and you get radiating back pain, you get arthritis everywhere, you get ligament thickening, and eventually this diameter of the spinal canal closes up, and it's known as stenosis. And this is our typical shopping cart sign. When you see people walking and they're leaning forward, it's stenosis, because if they lean forward, they anatomically can create more space for the nerves, and that relieves their pain. This whole process of facet, which is joint thickening, ligament thickening, disc cracking, all of this is known collectively as spondylosis, which is just a word to describe your spine's going to hell in a handbasket fast. So unfortunately, not a pretty picture. Now we get to grandma. Now we have the geriatric spine. And now, despite all the other aging that has happened with the disc degeneration, look, no white disc herniation, now we also get fractures, because now it's not just our soft tissue that is getting degenerate, it's also our bone. And the problem with fractures in our geriatric population is it's immense. The Surgeon General has described that 1 in 20 women are expected to have spine fractures in the next 10 years due to a couple of facts. We are aging, our population is getting older, we are starting to deal with a geriatric population that wasn't well nourished because they never took in enough calcium, they didn't get enough exercise, they didn't necessarily have enough vitamin D, and they're very sedentary. Their lifestyle has become very sedentary. So you can have a pure compression fracture, which means the bone is so weak it just collapses. But the dangerous thing here is that this picture that we see here can also be a malignant tumor. It could be the first sign of a metastatic tumor. That means you have breast cancer that nobody has diagnosed, and the first sign is this fracture, which is full of tumor, or it could be a disease known as myeloma, which is hard to diagnose if you don't think about it. It's a disease of bone marrow, where the bone marrow elements gets displaced by a protein that's pathological, and that then leads to the collapse because the bone marrow doesn't have the integrity. So let's look a little bit about bone health. If you're aging, your spine has both osteoporosis, which is weakening of the bone. You have osteoarthrosis, which is arthritis, which is the disc bulge, the thick arthritis at the back. And so look at this top part of the picture, pretty clear. The bottom kind of look a little shitty to me. And your discs get completely narrow. So from a nice white disc with enough space and a beautiful alignment, you go to disc herniation here, this degeneration there with stenosis, and you lose your curvature of your spine. You also get osteoporosis. So as you get older, there's a decrease in your bone mass. And there's an uncoupling of these two cells. So you have osteoblasts that build the bone, and you have your bone chomping osteoblasts, clasts that eats the bone. And these are in a constant symbiosis. If our bone was formed and never rejuvenated, we would be Humpty Dumptys or marble statues, and we would just crack. But the truth is that your bone gets replaced every 18 months. Your body constantly eats up old bone and puts down new bone, eats up old bone, puts down new bone. That's why we can heal from fractures. But if this process gets out of sync and you eat up more bone than what you can lie down, then you change the microarchitecture of your bone and it becomes less strong and it breaks. The third thing that happens to us when we're older is osteoarthrosis, which is just a nice name for arthritis, okay? What happens there is that we have little joints in our spine, and they are lined with cartilage, just like in your knee or your ankle, it's the same. And in this cartilage is cells called chondrocytes, and they have a protein content, and that's why it's so nice and slippery and joints can move. As we get arthritis, the joints get stiffer, and again, the symbiosis between the proteoglycan keratin and chondroitin sulfate, which makes up the cartilage, gets disrupted, and we get fibrillation of the cartilage. It gets little cracks like the enamel in grandma's teacup. There's less cells in the cartilage. It looks like they're dying, and the water content of the cartilage actually increases, so it kind of washes away your cartilage. So when we have this degradation from aging, then our discs lose water. When we have true arthritis, which is a disease, we get more water. But the same thing happens. At the end, it destroys our cartilage. So when the patient comes in, you can now see that the first thing you do is, when people ask you what's your date of birth, it's actually important for us. It's not just because we want to bill you. Because the moment you get an idea of the age group of the patient, you already, as a clinician, in your mind, form these differential diagnoses of where does this patient fit in. So the 23-year-old walking into my office with back pain versus grandma walking in with her back pain, both have back pain, two completely different diseases that I'm thinking of. So the next thing is that because the spine encases the nerves, it's very important to determine the neurology. So if I have back pain, but I don't have pain running down the outside of my leg, or I'm not dragging my foot, then it's more than likely a mechanical thing. But if I have back pain and there's a radiating pain down my leg, then I have to think nerve compression, two completely different things. Unfortunately, we know which nerve supplies which part of the body and the sensation on the skin. So if I examine you and I go like, well, you can't stand on your tippy toes and you can't lift your heels up, then I know I have to look at L4-5. So I don't have to look at C1, 2, 3 and all of this. So then we do x-rays, and basic x-rays are mandatory. An MRI, people always say, oh, I've got back pain, I've got an MRI. That's the worst thing that can happen to you. If you take 100 people off the street, 20% of them without any symptom of back pain will have an abnormality on their MRI. It will be a bulging disc or a facet cyst or a disc herniation, whatever. These things happen in our spines, and not everybody gets symptoms from it. So please, if you ever are in this unfortunate position of having back pain, please make sure that the physician examines you and that they don't treat your MRI. Because if you treat the MRI, you will over-treat patients and recommend surgeries that they don't need. So you look at the patient, the history is critical, you get this mind map, you examine for neurology, you look at the plain films to see if there is gross abnormalities or instabilities or tumors, and then if there's no neurological symptoms, if the patient doesn't have any nerve issues, an MRI is not indicated. MRIs helps us to look at nerves, to find occult fractures, and to find tumors when we suspect that. We do not do surgeries on MRIs. You make the diagnosis, and the MRI is to confirm that your diagnosis is correct. Other special tests that's very important is a DEXA scan, because that gives us an idea of the density of our bones when we look at osteoporosis. However, when we have scoliosis, these things can be inaccurate. We can also look at biological markers for bone turnover, which we don't routinely do, but you have somebody that's in an age group where they shouldn't have osteoporosis. There are lots of endocrinological conditions that can eat up your bone. Then we will rely on some blood tests. The MRI, again, I can't overemphasize this, is the test of choice when we're looking for soft tissue, disc degeneration, nerve compression, and it's ideal for early compression fractures. The CT scan, ideal for bone pathology, especially for destructing lesions, again, like cancer lesions, arthritis, joints, and we can also see nerve root compression on a CT scan. So let's look at the natural history of the aging spine. First of all, as we degenerate, we get height loss, and 50% of your height is carried in your discs, or 25%. So of your spine height. So if you start to degenerate your discs, you'll get shorter. And I'm sure if you haven't seen your mom or your grandma for a long time and you go to visit them, you'll go like, oh, grandma really got short. Means she has disc degeneration, okay? Our disc has an outer annulus fibrosis, which is like your steel radial tire. It encases the nucleus on the inside, which is like a ball of chewing gum. It's jelly-like. It has type 1 collagen. The collagen is obliquely oriented. It has a high water content and proteoglycans. It has a high tensile strength, and it prevents your spine from pulling apart. It remains flexible almost through all your life, which allows you for motion. It has this high collagen, low proteoglycan ratio. It has fibroblasts, which is a connective tissue-like cells, and it produces collagen type 1. The nucleus, which is the jelly type on the inside, is the internal part of the disc. This has collagen type 2. It is 88% water and proteoglycans. It's like an hydrated gel. And so this gel with the water and the proteoglycans can resist compression. It has a viscoelastic matrix. It has low collagen, high proteoglycan ratio. That's why it can allow compression and movement. It is more cartilage-like cells, and it produces collagen type 2. So disc herniation is not aging. People go like, well, I went hiking in the Dolomites, and I carried a heavy backpack, and I came back, and as I sat on the plane from Italy, I got this pain down the back of my leg. And people go, oh, you're getting too old. You shouldn't be doing hiking vacations. It has nothing to do with your age. You probably herniated the disc. That means that you overloaded that nucleus and annulus, and the annulus got a little tear, just like your tire when you hit the side of the road. And then that nucleus material leaks out, and that's a disc herniation. What we see when we microscopically look at disc herniation is that there's actually a pathological process. There's an increase of osteoprotein, which is a protein. There's interleukin-1 beta, which is an inflammatory thing. There's rank ligand, which we actually use for bone formation. And there's an increase in parathyroid hormone, which allows us to absorb vitamin D. Versus disc aging. I never had any of this, but I'm now 80 years old. And now you look at my disc under a microscope. There's no water in it. There's no nutrients. There's no viable cells. The pH is different. There's an increase in keratin sulfite and protein sulfite, chondroitin, which is like we find in the skin. There's lactate, which we find in when you overexercise. There's a lot of enzymes that eats up the discs. But there's no change in the quantity of the collagen. So don't think that you're herniating your discs when you're old. It's different. So let's look at vertebral compression fractures, the second thing that happens. Remember, the first thing was your discs that get sick, where you have the disc herniation, the disc degradation, and then the aging of the disc. 3 different components, but affects your discs. The end result is relatively the same because you lose disc height, you can't withstand the compression, and you get shorter. Now we come to the bone. So vertebral compression fractures are the most common fragility fractures. 700,000 compression fractures in the spine per year in the USA. 70,000 hospitalizations and $15 billion in annual cost. And to tie this back into women's health, you don't see any big research going on osteoporosis because it's not cool. It's just your grandma. It's just a bunch of older women. The demographics, 25% of people over 70 and 50% of the people over 80 years. If you have had a previous compression fracture, that's the strongest predictor of having it in the future. Your bone is normal, but the quality is decreased as well as the quantity. So the outside, the thicker bone, the cortices are thin. The inside bone, where you make your bone marrow, has holes in it. It looks like Swiss cheese. Your bone is at its strongest between ages of 33 to 40 years in women. After that, woman goes into menopause. They don't have their estrogen, their metabolism changes, and they start to lose bone mass. When you lose a critical amount, then we can define a T-score, which is how many deviations are you below a teenager normal. And if it's below, if you have more than 2.5 deviations below the T-score, then we say you have osteoporosis. When you get compression fractures in your spine, you get kyphotic, you hunch forward, you lose pulmonary function, and you can get heart failure. So if you have a compression fracture, 15% of people with their first compression fracture will die within the first year, and 20% will die at 2 years. So a compression fracture is a deadly disease. Osteoporosis is a silent killer. We all know that grandma fractured her hip because she fell. It's not that. Grandma fractured her hip and then she fell. The bone becomes so weak that it spontaneously breaks. So if you have a hip fracture, we know that 50% of our patients with hip fractures due to osteoporosis will die within 6 months after the diagnosis. So this is a very, very important disease. Osteoporosis is not on the radar screen enough, and you need to make your children and your grandchildren aware that they need exercise good diet, because you can only build up your bone when you're young. Once you're 33, you're done. This is what you have. Your mass is set, and it's only downhill from there. So here's an example. Here's a 83-year-old lady that comes in with an L4 burst fracture. So this is the sacrum L5. This is her fracture. You can see it's completely compressed, and it's lost almost 50% height. Okay, we opted to fix this for this patient. And this is another example. So we opted to fix this, but you can see what happened. She kept on leaning forward because she's lost all of this height. And eventually we had to do a surgery where we needed to restore her posture, because you can see her head was so far forward. So let's look at spinal stenosis. This is the third component. So first of all, you lose your discs. Second of all, your bone just disappears. And then third of all, then you get the debilitating pain because your nerves get compressed. By now, I hope that you're all very depressed, because this is not a pretty picture, okay? When we get spinal stenosis, this space where the nerves has to run become very small. And it's small because this disc is herniated, this joint is full of arthritis, and this ligament is thickened here. It looks like a V. So the central canal and the nerves that has to come out gets compressed. So the end result, we start up nice and pretty like Baywatch, and we end up like that we don't want to, like grandma. We lose our sagittal balance, sagittal like an arrow, or upright balance. And the deformity that we develop is in multiple planes. It is in the lower spine, it's in the thoracic, and eventually in our neck. Here's an example of a patient that had unbelievable osteoporosis. She broke her femur in several places and her hip, and had to have this custom-made prosthesis. She broke her other hip, she had a knee replacement, and now she presents with this severe scoliosis, and she has osteoporosis. So let me talk about the motion segment. This is the bone, this is the disc, this is the bone below it, and here's joints at the back. And so two vertebrae with a disc in between is a motion segment. So if the bone gets osteoporotic, the disc goes away, your joint gets arthritic, you're losing your motion segment and you become very stiff. And the end result is that a large percentage of women develop a degenerative scoliosis. They started out looking like that, but once they get in the 70s, they get the spontaneous rotation of their spine because it becomes unstable in multiple directions. It becomes a three-plane deformity. Here is an example. This patient, as you can see, is leaning over to the left. She's had these previous procedures to try and fix this, which was inadequate. Her spine is now uncompensating and just leaning over to the left. She's already had neck issues, and she has lost the complete dollar sign, that normal curvature. We are able to restore these patients, but these are massive surgeries. It takes more than a couple of hours. It takes about 8 hours. We're usually 2 to 3 surgeons involved, and the recovery is brutal. These patients, however, are extremely grateful if they look like this before, and afterwards they can stand up straight again and look forward and don't have to lean on a walker. Here's an example. This is unfortunately a 32-year-old woman who was abducted and locked in a basement, all these things that you hear about, and was mistreated by her husband, who then, or the man who abducted her and then tried to kill her. So she was beaten to the point where she had several compression fractures. She had a traumatic brain injury. She's lost all of her teeth and was finally discovered by the police. And so we were able to help her. But she had severe osteoporosis because she was malnourished for many years, and the traumatic brain injury makes this even more challenging to manage because people are spastic and can't cooperate in these big surgeries. but she and her parents were forever grateful that we attempted to help her. This is an example of that same patient, and I hope it's not over lunch, but this is what we do. We took out a complete vertebrae. This is her spinal cord. You can see that big, this is one vertebrae, we took one out, this is the one below. And in order to get her upright, we have to close that gap. And so here you can see before surgery. This is during the surgery, we've closed that gap, we've broken the screws off. The morning when you go to the operating room, and we had a 3D model, and this is what she looked like, and this is where we wanted to get. I must tell you, you ask yourself, is this really going to work? What was I thinking? How much was I drinking when I decided I'm going to do this? But you have to really work this out scientifically. So I looked up a little bit of your company. I saw that you're in artificial intelligence, so I thought I'd add this in here to show you what we have been able to achieve over the last 5 years. And I've been doing spine surgery for 23 years now, and we've never had this technology. In the past, you would take the patient to the operating room, the patient would look like this. You would take a straight rod and you would cut the bone and bring this up and try to do as best you can, and at the end say, well, this is the best I could do. Now we have software available. We can do 3D modeling. So we can do a 3D model, you can decide how to do it, and we can have a patient-specific rod made for that specific patient, which we then use as a template to know that at the end of the day, we need to end here. Otherwise, we haven't corrected that patient. The software is dramatic. Here is another patient of mine that has a condition known as osteogenesis imperfecta, where a bone wasn't formed normal at birth and subsequently had multiple fractures. She ended up, she was actually much worse than this. Her chin was down here. So 8 years ago, before we had the technology, this is what I did for her. And then last year, with the technology we got now, I was able to figure out with a computer how much I needed to correct her and where I needed to do what. I needed to bring her neck up here, and I needed to take a wedge out here, and then templated her to know if I get this rod in, she would be able to look straight ahead, and here she is. And she was delighted, and we became quite good friends. Unfortunately, I lost this patient during the COVID pandemic. This is what the computer program allows us to have. You can measure all these measurements now, the pre-op as they are. Then you can execute your plan and see where you want to change what, and then you can see what did you achieve with your plan. And to have all of this data together after all these years, putting all this data in this computer program, we can get predictive analysis. We can start to look at a patient and group certain patients into certain groups and see who's going to respond to what best, because every patient, despite our best planning, responds differently. Some people, if you fix their kyphosis, will all of a sudden look at the sky. So it's really hard to predict the compensatory mechanisms, and you can only do this if you have a critical mass of patients. We are 4 universities now, one in France, one in New York, and then Seattle and us, that have put all of our data together, and we have about 6,000 cases now over the last 5 years. And that pulling of the data and getting trends of what patients does is absolutely powerful. I wish I was 30 years younger. So let's get back. There's a few red flags when somebody comes with a back pain. If somebody has back pain, that is not related to a position. If I have back pain, when I go lie down, my back pain goes away, it's more than likely mechanical. But if I have back pain day and night, it doesn't want to go away. The pain wakes me up at night. It's not alleviated by Tylenol or an Aleve. I'm losing weight. I'm getting intermittent fevers or sweats at night, and I'm just not feeling good. That's a very big red flag. Then my back is part of a systemic disease, which can be infection or cancer. Okay. those patients we need to look at their livers, need to look at the calcium metabolism, we need to look at their blood work for white counts, see if they have an iron deficiency. We need to look at sedimentation rates and CRPs, which are general markers for being sick, either infection or malignancies. So now that I've completely depressed everybody, telling you that you're going to end up crippled, not really true. Unfortunately, at this point, I would say about 25% of women have all of these diseases. And anybody in their life will, at one stage or another, have some back pain, which is related to any of these conditions we talked about. So how do we prevent this? First of all, we have to eat protein-rich food. You can't just take in calcium. You need the proteins, which is the lattice work that catches the calcium, so you can build the bone. And you need to do that from childhood. You have to do impedance exercise. It's important to walk. Just walking, that little vibration that you get when you walk is so important. Your bone interprets this as pressure and it forms more bone. Stretching is phenomenal. Yoga, Pilates, core strengthening. If you can do these 3 exercises every day and 10 of each, this is the best exercises you can do. You don't need to go to a gym. You don't need to lift weights. Core strengthening. Weight training is important because it keeps your muscle mass. But I don't want you to be an Olympic weightlifter because that's not good for your spine either. So with that, I would say thank you. I hope that you enjoyed it. It was a smorgasbord. I touched on a lot of things a little bit. Wanted to give you a background on this. My take-home message is that women tend to get more of these problems that I showed today. Osteoporosis is almost exclusively a disease of women. When men get it, we look at cancer and smoking and alcohol. Those are the 3 biggest reasons, of which alcohol times 3 is the reason for osteoporosis in men. Occasionally liver disease, but also related to alcohol. But women get inherent weakness of their bones due to the fact that we have a process called menopause and we lose the ability to make bone. So thank you very much. Let's see what's in the chat box. Did I go too fast? Tumults. I have a 12-year-old girl with curvature of the spine, currently around 17%. Precursor most likely vincristine's final injections as a child. I'm sorry, sir. Doctor says it might be worsening due to onset of menstruation when it starts. Currently has no pain and does not affect her walking. Will this condition worsen as she gets older, and or other things we should do now to help minimize this later in life? So girls have their maximum velocity of growth is 12 plus or minus 2. So girls grow the fastest between 10 and 14. Boys grows the fastest between 12 and 16. It's a general rule of thumb. If she has a 17-degree curve, it's under the threshold for any treatment. We don't do bracing or anything unless the curves are at 25 degrees. The curve actually worsens right before the start of the menstruation. So she should have an X-ray at least at this time every 6 months. Because after menstruation, they grow another 18 months, but that peak velocity is right before girls starts their first menstrual cycle. There's unfortunately nothing we can do about that except watch this. Core strengthening, good protein. People who have scoliosis do have more osteoporosis. That's the things to do, but she needs to be watched carefully by somebody that understands scoliosis. Carly Phyllis, please type any, oh, okay. Winona Johnson, I've heard that strength training using hand weights can help with bone loss as you age. Is this true? If so, does this also help your spine? It helps overall, any kind of exercise, even if you take a can of beans and lift it, because if you can keep yourself agile, you keep your metabolism up, is much better than lying in bed. This is what we see now with COVID. People who survived it can't walk. If they've been in the ICU for 4 weeks, they lose so much muscle mass that we have to get them to rehab, and it takes up to 3 months before they can start walking. And I think we're going to see dire consequences on their bone. We haven't even looked at it. So I don't have any literature to tell you if it really helps for your spine, but because nobody's done that. But in overall, any weight you do, even arm weights, is great because it helps your circulation. And that's a big part of exercises to get your circulation going. An osteoporosis patient who has had 2 bone L1, 3, or 4 fractures, are there any preventions or supplements the patient can do or take osteoporosis? Yes, so my favorite topic. In the past, everybody said you had to take calcium and vitamin D. We now have a slew of drugs on the market for osteoporosis. The critical part is that your vitamin D has to be normal before we can put you on these drugs. One group of drugs will build new bone by regulating the osteoclasts so they don't eat up your bone. One group of drugs will help prevent your bone by making osteoblasts that lays the bone down faster. And then there's another group of older drugs that gets incorporated in your bone. So even though it makes your bone stronger, it makes it a little bit more brittle. They are not so popular anymore, but these new classes of drugs where we can control the process and allow your body to do it are extremely powerful. And most endocrinologists and rheumatologists can prescribe this. A certain amount of these drugs can be prescribed by your primary care physician, but if you have had multiple compression fractures, you should at least have a full workup, including a DEXA scan and some blood work to see what's the reason. Proven treatment for a pars defect at L5 other than a fusion. If you have a normal disc and you are a young teenager and you have a pars defect, which I've seen in high-grade baseball batters who are actually going to college because they've got a scholarship, we can repair that. We repair it with robotic navigation. Whether it's successful, I can't tell you that because it's very hard to get that little fracture to heal because of all the stresses on it, but you don't need a fusion for a pars defect necessarily. If you're an older person with a pars defect and it causes nerve compression, we can just decompress it. You don't need to fuse it. The most fusions we do are for people that have equal amount of back and leg pain in their middle ages with a pars fracture that is healed and fractured, healed and fractured. And so it's an interesting condition all on its own. Elena Roberts, okay, let me see. How do you feel about chiropractors? I, as a medical student, work with a chiropractor. I think you get chiropractors and chiropractors, you get doctors and doctors. I think some chiropractors are excellent because they really understand the pathology. I don't understand the concept of their treatment. I'm not saying it's wrong, I just said I don't understand it. Because when we have patients that has had fractures from high velocity injuries and car crashes, I can tell you, it takes a lot of muscle power to get that spine reduced under anesthesia. So I don't know how they adjust it when the patient's awake. So they are obviously doing things because it helps patients. If you have osteoporosis, be careful to go to chiropractors. I have also seen very bad outcomes from fractures and disc herniations. What are ways someone under 30 with no neck curvature in the spine and pre-arthritis can work to make a curve or prevent getting arthritis? First of all, I need to tell you, you should have picked your parents better because we see this in families. So I'm sorry, you picked your parents, it is what it is. you need to see get a good baseline to see if there's something underlying with this full x-ray view that I showed you today, to see if your neck is just a symptom of something else in your spine. You need a good examination, again, not an MRI, to see if you have any other joints that are arthritic. If this is determined that you just have a bad posture, then getting excellent training and physical therapy and adhering to these exercises like brushing your teeth is very important. Diet to minimize osteoporosis. So I'll tell you what a mentor told me when I was a young medical student. Now I'm only young, not a student anymore. So he would stand there in the class and say, so I'm seeing all of you future doctors, and I know what you're going to do. You're going to throw your parents away, and you're going to put them in an old age home. And then because you feel guilty, you're going to buy them an expensive rug. He says, but then they don't have enough money to buy the proper food. And then the money she gets, she buys meat for the cat, and then she drinks gin in the evenings. And that's your picture of osteoporosis. So first of all, you need to get exercise. You need good proteins. You need to avoid alcohol. If you eat a balanced diet, but make sure you eat enough proteins. We are so protein deficient. I'm not telling you to be a ketoist, but just make sure that you take in protein. And then something that we know is vitamin D is so important. We always thought that if you sit in the sun, you can get vitamin D. We now know that certain people are vitamin D deficient. And so to take vitamin D and have your vitamin D levels done once a year with your annual exam is really important. I don't know of any research in spinal bifida patients at the moment. I used to do both pediatric and adults, but the last 10 years I have stepped out of the pediatric arena because of this demand on the adults. So I can't tell you. I am sorry about that. Okay. Collagen supplements. We don't have science, but it doesn't mean that it doesn't help. That's about the best we can say. I think it will come. There's a lot of work being done currently on the microbiome of arthritis. The microbiome means that from the moment you're born and you get through the birth canal, there's a certain colonization of your skin and your body from bacteria that you get from your mother. Now we know that certain bacteria in certain patients and in their gut contributes to the formation of toxins in the body that can possibly precipitate arthritis. So I am blessed to have a good group of PhD researchers here who's just got a $4 million NIH grant looking at the microbiome of arthritis. So I think that there's going to be lots more to come about probiotics and what we do to change the bacteria in our gut, because it's clear that there are some toxins that can precipitate a lot of these diseases. My mother is 49 years old now, and she had hysterectomy at age 23 or so after 2 C-section deliveries. In late teens, she had pain in her lower back for nearly 15 years after hysterectomy. Used back support for 10 years. She's been doing fine the last 10 years of occasional pain through her left leg, but I'm concerned about what I can expect from my mother in the coming years as a result of her hysterectomy surgery. Yes. Your mother is a great risk for osteoporosis. If they did a hysterectomy and they kept her ovaries, she at least had estrogen till she was about 40. Without a uterus, we sometimes get early menopause. So she is at great risk for osteoporosis and should have a DEXA scan and be seen and start on medication sooner than later. So I would suggest she sees an endocrinologist. Ergonomic chairs. I don't know about a brand, but as you can see, I'm sitting back. I can tell you, sitting through this COVID, I had calluses on my butt and my back hurt. And I realized the value of a good chair. And every chair is different for every person, just like any bed. And you have to find a chair that fits your posture. So sit in it, don't just buy it. And I don't have a recommendation for a brand. Okay. We talked about collagen. No evidence on whether sparkling water is bad for the bone. Any water is better than being dehydrated. Inversion tables, interesting. They work for a while, but because of that viscoelastic properties of your disc will, after a while, give immediate resistance to the traction. So people find that they work for a while, and then all of a sudden, if they lie on it, it doesn't help, because your disc got used to being distracted, and the moment it gets that tension, it gets a rebound. So it doesn't help. Sciatica, next question, is the common word for pain that radiates down your leg. So your sciatic nerve gets nerve roots from L2, 3, 4, 5, and S1. And all these little nerve roots come into one nerve known as the sciatic nerve. So once the pain is in your sciatic distribution at the back of your nerve, we still don't know which level it's coming off from your spine, and that's where MRIs are helpful. I have no idea about distilled water either. I don't read this literature, and I don't see anything in our scientific literature about that. What can you do with an 8-year-old son that doesn't eat? I have a 30-year-old that doesn't eat. He weighs, this scrawny kid weighs 123 pounds. When he was little, I could beat him. Now I'll go to prison. There are actually, in a more serious note, there are now food clinics for children that do not want to eat. We have some of that at Children's Hospital, where they actually, we find that these children are very intelligent that don't want to eat. And they actually teach them about food, and they expose them to different tastes. And so I know of a little 4-year-old that's in this food clinic. You should look into that. Standing does benefit the strengthening of your bones and your posture. So if we have paraplegics, patients that are in chairs, it's our goal to get them standing in a frame, just so that they can put weight on their legs. So standing desks are excellent. Plantar fasciitis is not necessarily related to the spine. It is a separate entity, and you should see a foot and ankle surgeon for that. And I think that made us run through all the questions. I'm sorry that I went over time. Hope you all enjoyed it. Thank you very much for tuning in, and take care of your backs.
Dr. Burger, thank you so much for your time. I appreciate you sticking with us while we went over a few minutes. I know that everybody, again, everybody really appreciates it when you answer questions because it's personal to them. So from all of us at Arrow, thank you for taking your time. I really, really appreciate it. I thought it was a great talk. And again, thank you again. And for everybody, thank you for participating. Appreciate it very much.
Thank you very much. Enjoyed it. Have a good day. Bye-bye.
You too. Bye-bye.
Thank you.